talk, I would like to invite Dr. Mashhood Qazi, who is a trained emergency medicine and pre-hospital care provider in UK. He's gonna to talk further on the topic as we discussed. Thank you.
Assalamu alaikum, everyone. Good morning to all the participants. Amazing conference, I must say. It's a privilege to be in Karachi, always is, to be in Pakistan. This is the second conference, and I hope, pray, and wish it just grows and grows to an extent where this conference becomes a gold standard in trauma care, not just in Karachi, not just in Sindh, but all over Pakistan. And excellent presentation by Dr. Benish, which has set the tone for my topic, which is scoop and run. And my esteemed colleague is going to discuss about stay and play. Now, we need to remember that in well-developed trauma setups where pre-hospital care is has matured enough, this discussion is redundant. So we don't discuss this anymore, scoop and run or stay and play. So that's situational-based, scenario-based, resource-based, and that's what we're going to talk about. But we need to understand in Pakistan, this is still a hot topic. Do we scoop and run? Okay. Should we? Oh, okay, sorry, thank you. Lovely. So just a disclaimer, it's educational purposes, awareness purposes, there's no monetary involvement, and my personal views are included. So I'm a big fan of cricket. So Dilshan, the Sri Lankan player, was the inventor of scoop. Obviously, we're not here to talk about cricket. We're talking here about a very serious topic, which is pre-hospital care. So this is a picture. It's just for the scenario discussion purposes. It has no other implications. So I was in Mexico a few months ago. Surprisingly, in Mexico also the pre-hospital or a trauma scenario is not much different to this picture. So what you can actually see is there's been some sort of trauma happened on the street with a lot of law enforcement agencies around. So the question really comes to mind, is it safe to send an emergency medical team to the roadside, to the trauma scene before the scene is secure? Or should we wait for the scene to be secured and then send our resources in? Pretty similar picture. There's a mob which is surrounding a car accident. Again, could be a charged mob. So how safe is it to send your pre-hospital team straight away? So decision really at that point by the pre-hospital team is, should we scoop and run, load and go, or should we stay and play? So this is what we're going to talk about briefly. It's a hard topic to discuss, but because as I mentioned, this debate is redundant in the developed networks. Just a brief introduction. I'm a fellow from Royal College. I'm a CCT master's. Previously, I worked at Whipps Cross in Royal London. Royal London is a major trauma level 1 center and one of the pioneers in trauma care in the UK. I've been associated with Essex and Hertfordshire Air Ambulance, luckily, and been lucky enough to be commissioned with the British Army. And since 2018, been associated with Abu Dhabi Healthcare Services, and also been working in Saudi Arabia from time on and off. So this is where my journey started, from the pre-hospital, Essex Air Ambulance, wonderful service, charity-led. So as I mentioned, if we are working with the Essex Air Ambulance, we're not going to be discussing about this talk, whether we scoop and run or stay and play. We will go in with all the resources and assess at the scene. But obviously, if the scene is deemed to be unsafe, then what we actually do is we wait for our armed response teams to give us a RV position where we go with them. So a lot has been learned from the military service. Remember, some of the trauma scenarios in the pre-hospital setting are not much different from what happens in the war zones, because you have a lot of noise on the scene, a lot of chaos. What our military colleagues do in those scenarios, they just scoop and run. So this is a phenomena which is a standard of practice in the military setup because of the very hostile environment. But if the hostile environment is not there, obviously, and you have the resources, why not? You can just stay and play if you need to. So some of the factors and confounders which will really help you make a decision whether you scoop and run or not are the scene dynamics. Obviously, scene dynamics changes minute by minute. The mob can become more and more aggressive towards anybody, actually. And the first people who go on the scene, they might get the blunt of the aggression. So again, multiple patients, casualties on the scene makes the scenario quite difficult for the pre-hospital teams. Again, decision needs to be made. Complex trauma patients, and most importantly, do you really have the skill sets to stay and play? Or if you don't, is it not better just to scoop and run and take the patient to the nearest facility, which can stabilize the patient, and then the patient will be transferred to the level 1 trauma center as a primary retrieval transfer. And local culture is very important. Remember, the culture working in the UK is completely different. How we as physicians are perceived on the scene is much, much different to how we as physicians are perceived in Abu Dhabi, for example, because over there you're not allowed to take pictures, you're not allowed to interact with anyone at the scene because the big crime if you do get involved in at scene. And so we feel completely safe when we go to Abu Dhabi pre-hospital scenes. In UK also, certain areas, for example, East London, you cannot walk on the scene with a branded watch because the first thing you're going to get is you're going to get stabbed in East London. Again, dynamics in Karachi are probably different to the ones in the UK and Middle East. The folks working here probably know much more than I do what the dynamics of Karachi is. The most important factor which I think which you need to assess on the scene based on the casualties or the injuries they have sustained is where's your specialist hospital at? Is it half an hour away, 5 minutes away, an hour away? So if your specialist facility is just 5 minutes or a couple of blocks away, why don't you just put it in the back of the ambulance or a private car and take him over there where you can get the resources? So some of the golden rules is very simple, and I'm a guy who keeps things very simple. If your team is at risk, you need to make them stop before you go in, because your safety comes first, because if you are no good to the patient, you're not going to do any good to the patient anyways. And then obviously we need to prioritize patient care. So I'm going to run through the slides because I have 50 seconds left. So dynamics of course, we talked about it. If it's unsafe, if there's a violent crowd, environmental hazards, building's going to collapse anytime soon, there is no point going and staying. You just have to load and go. We've talked about that. Multiple casualties. So if you have a lot of casualties, the basic rule is the minimum you do with the casualty is the best thing to do, because you can, with the limited resources you have at the scene, you don't want to exhaust those resources with treating 1 or 2 patients. The minimum things you can do and move on and move them to the specialist care is the best thing you can do. Dr. Binish has mentioned about the golden hour. Now, skill sets becomes very important. So if I am just riding with an EMT or a driver, and I don't have the skills, I don't have the equipment, there is no point for me to stay and play, because what I'm going to play with, because I don't have the equipment. So just to remember what the couple last slides were, yeah, so skill sets are very important. You have to have the life set. And remember, back in 1990s, the concept of ambulance service in Pakistan was just a cabin car with a stretcher. They didn't have a cylinder, they didn't have an oxygen mask, and there was just a driver. And that was called an ambulance. So wonderful work done by 1122, which I've just seen a video. At least they have an organized system, properly trained people, EMTs, paramedics, doctors, and most importantly, they have the resources which go to the scene. So what they do might be different to what certain other ambulance services do. Again, comes to the point, we have to standardize the EMT care at some point. So Punjab has done it, why can't Sindh do it? So anyways, I'll leave it to this. Thank you very much.